Okay, we got one more, just give it another second. Hi, David. Hi, Laura. Hope you guys can hear us. Can you hear us? Hey, Laura.
Hey, yes, I can hear.
Okay, excellent. David, can you hear us? Dave? Let me just shoot him a quick chat. David, I'm going to assume you can hear us. Everybody else could. So if you can't, just shoot us a message in chat, okay? All right, it is 1:03, so I'm just going to go ahead and kick off, everybody. Welcome, and thank you all for coming to our webinar session on navigating healthcare. I think the important thing for us is that we want you to know that we do understand that as a parent or caregiver of a child with CdLS, healthcare system can be daunting. And we get your calls, we get your emails, and we hear you. And that's a big reason why we're putting this webinar on today. There's so many aspects to a good healthcare experience. One, as a parent, you want to feel confident that the medical provider that you have really understands your child's condition. You want age-appropriate care. Adult care is very different than pediatric care, and sometimes there's extra layers that are involved with adult care. There's the trial and error nature of medication, and certainly care coordination between the various providers. But today we want to really just focus on one of the key instruments underlying your healthcare experience, which is the plan itself that you have. Your healthcare plan in many ways is a blueprint of the services that are available to you. And today we're here to help you with a presentation that we hope that you find informative and actually helpful for your CdLS journey. So without further ado, I'm going to turn it over to the dynamic duo of Gabby and Linda.
Thank you so much, Bonnie. Hi, my name is Gabrielle Nadeau. I'm the Communications Director at the CdLS Foundation and your host for today's webinar. Before we start the presentation, I just want to go over a few housekeeping items. Again, the webinar is being recorded just so we can share it with you all after the webinar today and along with the rest of the CdLS community. Also, you all are muted on the call today. If you're not, please do so now. I noticed that we all have our names in the participant list, which is great. As I mentioned earlier, or I guess I said that already about the webinar being recorded. Also, our speaker, Linda, will be answering questions at the end of the presentation. So during the presentation, if you guys have questions, just put them in the chat box. I will read them to her and she'll answer them. If we do not get to the end of all of your questions, we'll gather the rest that we didn't get to and answer them. And if you think of questions afterwards, please submit them to our Ask the Expert portal. I'll put that website into the chat box, or you can send them directly to the Family Service team. I'll put their email address in the chat box. So those are all of the housekeeping section. And now I'm going to pass it over to Linda Pierce, who is the Director of Family Service, for her to do the presentation. Thank you so much for joining us, community, and for Linda. Thank you so much.
Okay, hi everybody. I'm Linda Pierce. I am the Program Director for Family Services. It's nice to meet you all. Today we are going to be talking about navigating your health plan and the best way to get the most out of your health plan, the best way to select a good health plan that meets the needs of your family, and how to advocate within your health plan for the services that you need. Oops. So there we go. Sorry, not really sure why things are not changing. This is actually our agenda for today. So this is our agenda because navigating a health plan, it is a rough road. It is filled with potholes and details, detours, and language that you don't normally use in conversation. And it can be very confusing, and advocating through your health plan and the healthcare system can be very difficult. And our goal today is to go through most of these topics to help you smooth out the road and provide some good tools to getting through some of these detours and road closures that exist. And we're going to start at the very beginning, which is where do people get their health insurance? Because he's our first little guy. And in the United States, over half of us, 52% of us, get our health insurance from our employer. And some employers offer a lot of choices of plans and others do not. Larger companies, like those with a national or a multinational presence, can offer more choices. It is important to remember that employers negotiate with different health plans and craft choices that work for them, balancing what they feel is most important to their employees with what they can afford as the cost of health care goes up. And the cost of health care is shared between the employer and employee contributions. That's the part that comes out of your check. About 18% of the population gets Medicare, and that is generally thought of as for the aged, blind, and disabled. 17% benefit from Medicaid. But about 10% of the population gets individual insurance through the health exchange. That is through the Affordable Care Act, or some people still call it Obamacare. And about 3% of our population is active duty military or their families that get their insurance through TRICARE. For those of you who are math wizards, you can see that this is over 100%. And that is because some people can have more than one health insurance within the year, or more than one health insurance at a time. And so how do I pick, if my company offers me choices, how do I pick what works best for my family? Because not every family is the same. So you want to evaluate your choices and make the choice that works best for you. And here are some sort of rules of the road. There are different types of policies, and these are three that are. One is an HMO, or health maintenance organization. And as you can see by this little guy with the umbrella, this works best for people that are basically healthy, that need health insurance on a rainy day. It is generally lower cost, less money out of your paycheck, but often more limited. So you can have no out-of-network coverage, or a little bit of out-of-network coverage. You can have limited benefits, but it's a lower cost. For families that live in an area that has a ton of providers, like in the middle of New York City, where every place you could ever want to see a provider is in network, this could work, but it doesn't work best for every family. The second type of policy is a PPO, or preferred provider organization. And this little suitcase sort of means, have a suitcase, I can travel. So it is a higher cost. It's usually more out of your paycheck to pay that employee contribution, but it usually comes with a bigger network, more generous out-of-network coverage. Even if you pay more for going out of network, it usually is a benefit. So you have more choice, but you're also paying a little bit more. The third kind is really something we didn't used to see, but now is much more common in what employers offer, and that is a high deductible health plan, the HDHP, and that comes with a health savings account. So what an HDHP is less is taken out of your paycheck, so that looks good when you first look at it, but the deductible, and a deductible is the amount that you have to pay out of your pocket before the health insurance company pays a provider anything, is usually higher. And sometimes that deductible can be $4,000, $6,000 for a family. So it is usually an extensive network, and it's usually a little bit of money coming out of your paycheck, but you have to spend a lot of money on your health care to meet that deductible before your health plan will start reimbursing a provider for services that you received. In order to offset that high deductible, the HDHP plan comes with a health savings account, and you put money in your health savings account that goes in pre-tax, and you use that money to pay the medical bills that come that till you meet your deductible, or that are for copays or co-insurance, or for services that your health insurance company does not cover. Some employers put money into that HSA to help employees have a bigger bucket of money in their HSA, but others do not. So it is really important, if that's an option for you from your employer, to really take a look at the details and see what works best for your family. Now, learn the language. So oftentimes when you get information about your health plan, the terminology that used is not really used in regular conversation. So it does make sense to learn the language about who makes decisions, what are they talking about money and payment, and what are the terms I need to know when I'm trying to access care. So these are health plan terms about payment, and they're not all of the health plan terms about payment, but these are the biggies. So the premium is the cost to keep your insurance, and it is paid individually. If you get your insurance through the marketplace, you're paying the premium by yourself, or your premium can be subsidized from the federal government. If you have ever lost a job and tried to get COBRA, and you realize that that payment for COBRA is like $1 gazillion a month, that is because you as the individual are taking on the 100% of the cost of the premium. Typically, from an employer, the cost of the premium is shared between the employer and the employee of what comes out of your paycheck. The deductible, like we talked about, is the amount that you pay out of pocket before your insurance pays anything to a provider. And that is an important thing to keep in mind. How much is my deductible for an individual? How much is my deductible for the whole family? And am I going to meet it? Your copay is a set amount that you pay every single time you go to a provider. And most of the time it can be set up where your copay might be $1 amount for a primary care provider and a different dollar amount if you go to a specialist. So for example, my insurance is $25 every time I go to my primary care provider, but it's $40 when I go to a specialist. But no matter what specialist I go to, it's $40 as long as they're in my network. And no matter what primary care doctor I go to, it's always $25. Co-insurance is something totally different, and you will see co-insurance come into play when you see a provider outside of your network. And co-insurance is a percentage, so that's not a set amount. A percentage is always going to vary. It's a percentage that you pay for covered services after your deductible is met. Because remember, your health insurance isn't paying anything to anybody until that deductible is met. So sometimes on your policy, you'll see, hey, if you go out of network, we're going to pay 80-20. And that means that once your deductible is met, if you see somebody outside of your network, the health insurer is going to pay 80% of the contracted rate, and your patient responsibility is 20%. But that dollar amount is going to change because it's a percentage versus a flat amount like on a copay. Out-of-pocket maximum. And this is an important thing to know, because even your employer and your health insurance company knows that there has to be a limit to how much we have to pay as individuals before we can no longer take advantage of our health care benefits at all. So the out-of-pocket max is the maximum you pay in deductible plus copay plus co-insurance. And once you reach that out-of-pocket maximum, your health insurer should pay 100% of the care that you receive. But this out-of-pocket max, as well as your deductible, resets every benefit year. And I say benefit year instead of calendar year because some people's insurance goes January to December. Other people's insurance goes July 1st to June 30th. And some people have insurance that starts at a different time because you might have started a new job and perhaps your insurance starts 30, 60, or 90 days after your hire. So every benefit year, these amounts reset. The last three that kind of go together about payment are bill, claim, and explanation of benefits, which is EOB. A bill is something you get in the mail or online from your provider, and that needs to be paid. A claim is something that your provider sends to your insurance company, and they want to be paid for their services. They have submitted a claim. And the explanation of benefits usually comes to you from your insurance company. And on the top, it will say, this is not a bill. And that tells you, hey, your provider submitted a claim for this date of service for this amount. This is what we paid. This is the patient responsibility. But then you're waiting for a bill to come from the provider. The importance of knowing these distinctions on bill, claim, and EOB comes when you have to call your health plan and ask them to research something. Because if you're calling customer service and you start saying, hey, I got a bill, they're thinking, well, that's got nothing to do with me because bills come to you from your provider. So it's helpful to say, hey, my provider submitted a claim. This is what I think I owe, but this is what they're charging me. Can you see if they submitted a claim? Can you tell me what you paid on it? Can you reinforce for me what my patient obligation is? So it is important to use the same words that they use sometimes because it will get you further when you're trying to resolve something. Health plan terms about accessing care, and this is far more interesting because it is about obtaining care, is a covered service, is anything, a good, which is a thing, a good or a service, a visit, that the health plan will pay for if it's deemed medically necessary for you. So there's certain services that are never covered, and those are called benefit exclusions. And the one that always comes to mind from a place I used to work is tattoo removal. Tattoo removal was considered a benefit exclusion because it was never deemed to be medically necessary. But for example, in my current health plan, a hospital bed or a wheelchair, they are a covered service, but they're not going to be covered for me because thankfully, I don't need them. They're not medically necessary for me. So there needs to be something that is covered, and then it needs to be deemed medically necessary for whoever it is being requested for, which brings us into, well, how does the health plan define medically necessary? So medically necessary are services that either diagnose a condition or treat a condition. So it can include testing. The health plan has to consider these services the standard of care. So the health plan really can't consider that service you're looking for as experimental or investigational, like a clinical trial. A health plan's not going to pay for because by definition, a clinical trial is an investigation, or they're not going to pay for things that they consider always cosmetic. And of course, there are some algorithms for deciding medical necessity, and there is some gray area which comes to why we need prior authorization or why the health plan feels that they need prior authorization. And a prior authorization or a prior approval is when the provider that is requesting a service for you, your family member, your child, submits clinical review. This is why I think my patient needs whatever. And the health plan reviews that clinical information and makes a determination if they think that good or service is medically necessary for that person. Now, how prior authorization works is, like I said, there's usually an algorithm of sorts. Clinical information is submitted. Sometimes the health plans are really clear about what they need to see. So if they want to see what medications have you tried before the doctor wants you to try you on something else, what more conservative treatments have been tried and not been successful before the doctor wants something that is less conservative. Sometimes they're very clear about what clinical information they wanted submitted so that they can review them. Sometimes they're not, but sometimes on their website, there will be clinical policies. This is what you have to have in order to for this service to be deemed medically necessary for you. And it's worth it to take a look to see if it's up there so that you know your provider is submitting exactly what they're asking for. When the information gets submitted, a nurse can say yes, but a nurse can't say no. So a nurse can look at what is submitted and say, yes, this meets criteria and approve it. But if the clinical information submitted does not meet the criteria, the nurse then has to send it to a doctor who will review it again and make the decision of whether to approve something or to deny something. And now we go to denials and appeals. A denial is either when all of what is requested is denied, or sometimes partial. You can have a partial denial. Part of what is requested is denied. For example, if you need physical therapy and the physical therapist sends in a request for prior authorization for 25 physical therapy visits, the health plan may say, all right, we'll approve 10. And then we want to see some more clinical information to make a determination on the next 15 visits. So after those 10 visits, we want to see, is this patient making the gains that the physical therapist thought they would make in the 10 visits? Does this physical therapist have a good plan of care or a treatment plan for the next 15 visits? So sometimes you can have a partial denial because they want to make an interim review in the middle. If there is a denial, you always have appeal rights. Every denial comes with a denial letter and appeal rights, and the appeal has to be a review of that good or service by a different clinician than made the first denial. So if Dr. Smith says you don't need this surgery, then Dr. Smith can't do the appeal because Dr. Smith can't say, of course I was right the first time, I am going to uphold my decision. It has to go to another doctor. In-network and out-of-network. In-network providers are providers that have a contract with your health plan. So they've contracted to be part of the network. They've contracted for a rate for different services. A lot of times they've contracted for a time frame. I have to get this person in within X number of days if they say it's urgent, or X number of days if they say it's not, or within 7 days following a hospitalization. So in-network providers have a direct contract with your health plan. Out-of-network providers do not. They don't have a contract with the health plan. So there is not a negotiated rate. So that is why that co-insurance is a percentage rather than a flat rate, because to go out of network, there's going to be some negotiation on how much the health plan is going to pay and what is your responsibility going to be. Care management. A care manager is usually a nurse, but sometimes a social worker from the health plan. They are an employee of the health plan. They help coordinate care. They should be able to help you find in-network providers. They should be able to tell you more about your covered services. And they should be able to talk to you about and enroll people in the special programs that they offer. And most health plans do have a special program, a care management program for children and adults with special health care needs. And they should be able to coordinate those services. Often the care managers also have their own support staff, community health workers, or someone who is trained in that way, who can help families to fill out some forms, who can also help families find local resources in their area. So that's definitely a helpful service that is worth investigating within your health plan. So advocating within your health plan. So now I sort of know something about it. How do I make this mess work for me? And these are good things to keep in mind. First, read the fine print. So it is the benefits. Usually you will get benefits in a member handbook, or you might be getting something that's called a benefit summary document that goes through all of your goods and services. Sometimes on the website of the health plan, there'll be a chart. It's usually pretty noble global, but for details, you really want that member handbook or summary document so that you can read exactly what is covered, what is not covered, what needs prior authorization, how much is my deductible, what is my coinsurance if I go out of network, what is the process for going out of network. All of that is in the fine print about benefits. You also want to know who's in the network, especially if this is a new insurance for you. It's a different benefit year. Maybe you or your spouse are looking at these new options. Maybe it's a new company. Maybe your same company is negotiating and contracting with a different health plan. So this is a different health program that you're being offered. If you have current providers that you see and you want to make sure you can still see them, make sure that those current providers are in the network. And then if I'm looking for other providers, how do I find out if these other providers I'm looking at are in my network? And most health plans will have a forward-facing online provider directory. And that is one place to look to see if your provider is going to be in network, but it is not the only place to look to see if this provider is going to be in network. Most online provider directories are voluntary. So the providers decide whether they want to be listed in the online directory or not. And some providers, especially subspecialists, may say, you know what, I don't really want to be on the website because I'm a neurosurgeon and I don't really want people calling me saying, hey, I saw this program on TV and now I think I need a neurosurgeon. They really want that referral to come from either your primary care provider or a different provider that has already examined that person, done some clinical evaluation, and says, yeah, you know, here's a neurosurgeon. I think this is your next step. So you can always call your health plan customer service and say, I didn't see Dr. Smith's name on the provider directory. Can you tell me if they are an in-network provider or not? And then you also always want to know if you have out-of-network benefits and how to access them and what will be your patient responsibility if you go out of network. Prior authorization, like we talked about before, and this is like this little, please let me go there. Does something I know I need, is that one of those things that requires prior authorization? And do you have a clinical policy that tells me what information you need to review in order to approve it? And then also, whose job is it to get that prior auth? Because in some health plans, it's the provider's responsibility. And if the provider is supposed to obtain prior authorization and they don't, and so their claim gets denied because that service was supposed to be prior auth and it wasn't, in some health plans, they can't bill you because it was their mistake. They neglected to get prior authorization. And so their claim isn't going to pay, but they can't bill you because they're a contracted provider. And one of the provisions of their contract was that they were supposed to ask for prior authorization. So part of it is knowing whose responsibility is it and what happens if I get a service that required prior authorization and there was no prior authorization requested. Denials and appeals, if all or part of my service is denied, what denial notice should I be looking for? How do you send it? Do you send it in the mail? Do you email it? How do I get it? How many days do I have to start my appeal process? There is always a timeline. And if you miss that timeline, they're not even going to review what you submit for your appeal because you asked too late. How many levels of appeal are there? There are usually multiple levels of appeal available, and the last level of appeal should be outside of the health plan. So the last level of appeal should sometimes be with your Department of Insurance, or each state has some equivalent. How do I speak with the appeals and grievance department? There are usually nurses that run those appeals. How do I speak with them? And also, if my doctor submitted something that was denied, is my appeal being reviewed by a like specialist? And that's a good term to know, because if you are an adult and your neurologist submitted a prior authorization request or a request for a service and it was denied, you want to know on the appeal, is another neurologist reviewing this clinical information? Is another neurologist available for my neurologist to speak to? You want to know if your appeal is reviewed by a like specialist. Care management and special services. What do your care managers do? And how do I request one? And do they have those support staff, those community health workers, or something else that is like that to help locate and apply for other local services? We also have a tip sheet for tips that are getting the most out of your health plan. It is a nice grid we've put together with kind of what do I need? Where should I look for that information? And if I'm calling my health plan, what do I say? And if you would like this tip sheet, you can certainly, or other resources, you can feel free to email us and we'd be happy to send it out to you. We also know for commercial insurance, parents want to know, how long can my child remain on my parents' insurance? And part of this is federal law, and then part of this is changes by the states. On the federal level, all employer-based health plans and all insurance programs that you buy off the health exchange, that Affordable Care Act, all of them must cover dependents until the first day of the month following their 26th birthday. So if your child turns 26 in June, they should be covered through June 30th or until July 1st. Some state laws or some states expanded that. So some states required some health plans to cover children over 26 who have a disability and who are not capable of self-sustaining employment. There are often different rules around that. Sometimes the child has had to have been covered by that plan previous to when they're 26, sometimes not. You can find your state insurance laws at this website. And also, sometimes employers take on the risk of the cost of care in their health plan. Those are called self-insured plans. And often the child, again, needs to be covered before they're 26 in order to remain covered after they're 26. So in those, you can check with your health insurance administrator or maybe your human resources person at work. And here again is the website to find your state's insurance laws. But the basic bare bones is till the child is 26 is federal law. And then different states have made different provisions above and beyond that. Medicaid. So what is Medicaid? Why do I want it? How do I enroll? Is it going to help me? Well, what do I do with all of this? Because it is a rough road. One more step in our rough road. So Medicaid. Medicaid is a joint program between the federal government and all the states. So here's the federal government giving lots of money to lots of states. And Medicaid can be your primary insurance or Medicaid can be your secondary insurance. So a child can have, under certain circumstances, commercial insurance from a parent who gets that insurance through work. And because they have additional needs, their Medicaid is secondary to their primary insurance. Medicaid also has two types of eligibility that have to be met for anybody to qualify for Medicaid. There's financial eligibility, so there's an income limit, and there's non-financial eligibility. So you have to be a US citizen, or you have to have been here and met your 5-year waiting period to become a qualified non-citizen. So mostly you have to be a citizen or a permanent resident, and there are financial eligibility criteria. So there's both financial and non-financial. The federal government requires core groups of the population have to be eligible for Medicaid in every state. And children and adults who receive Supplemental Security Income, or SSI, are one of those core groups. And the federal government also mandates a core set of mandated covered services in each state. But just like states can modify the requirements for keeping your child on your insurance after 26, the states can also modify the criteria for Medicaid. So a state can set a different limit for income eligibility. So the federal government can say, our income limit is, I think it's 135% of the federal poverty limit. Different states could say, we're either going to stay with that baseline for the federal requirement, or we're going to up it. We're going to pay for people up to 185% of the federal poverty limit. Also, non-financial, everybody has to be a US citizen or a qualified non-citizen, but states can waive that 5-year waiting period if you come here from another country for lawfully residing children or pregnant women. A state can decide, you know what, we are going to take care of these folks, even though they haven't been here for 5 years, because the risk and the cost of not taking care of them is greater than the risk and the cost of offering them health care. States can also expand the population groups that are eligible for Medicaid. So if your state offers Medicaid for single adults aged 19 to 64, they are a Medicaid expansion state. And when you hear that term about Medicaid expansion, really what that is a state deciding that they are going to expand the population groups above and beyond what the federal government requires. There is a small set of federally mandated covered services under Medicaid, but states can expand covered services. There are many lists of state optional benefits, and your state legislature makes that decision on whether or not some or any or no of those state optional benefits become part of your state's Medicaid package. And each state has a lead agency that administers Medicaid benefits in your state. So why do I want Medicaid? Well, really, it can prevent or reduce that medical debt that comes from meeting your deductible, your copays, your coinsurance, non-covered services. There are services that are not generally covered by insurance that you get from an employer, like private duty nursing, which can be covered under Medicaid. How you enroll is you find the lead agency in your state, and this website will take you there. Review the agency website and learn how Medicaid is administered in your state. Most states have multiple managed care plans that administer Medicaid benefits in your state. And if your state offers a choice of those health plans, it's really worth it to compare them to see, okay, are my doctors in this network, but not this one? And in many states, hospitals can help people enroll into Medicaid during a hospital stay, especially if there's a baby born that spends a good amount of time in a neonatal intensive care unit. And the other way to apply for Medicaid is to apply for SSI, because if your child is eligible for SSI, they are automatically eligible for Medicaid. And that is a big thing. So SSI, what is it? Who's eligible? How do I apply? And really what I should offer or have added here is it worth it to apply? Because it's really a lot of work to apply for SSI. So how do I apply and what is it? SSI is Supplemental Security Income. It is a federal program, so it's cash assistance. And the nice part about that is that the rules are the same state to state because it is a federal cash assistance program. SSI payments are made to help the aged, blind, and disabled who have a limited income, so there's an income eligibility part, meet their basic needs. It is never meant to take care of everybody's needs. That's not how it was written. The maximum amount of SSI payments in 2023 is $914 a month, and that is a little bit of an increase from last year. Some states supplement this with their own cash assistance. So in some states, folks that have SSI can receive more than that $914 a month. Like Medicaid, there are financial and non-financial eligibility criteria. The non-financial is you have to meet the Social Security Administration's definition of disability. And the financial is there are a lot of SSI income eligibility guidelines, and they're often very confusing. But if you're eligible for SSI, you're eligible for Medicaid. And that is really what can be so helpful for so many families. And we're not going to go through every single detail, but I will go through enough. But we do have more detailed resources if this is something that you're considering for your family that we can go over on a one-on-one basis. So the Social Security Administration defines disability differently for those who are children under the age of 18 and for those who they consider adults, age 18 and over. For under 18, the disabling condition must result in marked and severe functional limitations. And of course, that is a quote because that is not how people talk. And 18 and over is the disabling condition must result in the inability for substantial gainful activity, so work. The other thing that is part of this definition of disability is the Social Security Administration has something called the Compassionate Allowances List, or the Compassionate Allowance Conditions. And what this list is a list of diagnoses where the Social Security Administration has determined just because you have this diagnosis, you must be disabled, which really elevates or escalates that clinical review process of determining whether someone meets the definition of disability or not. Because if your condition is not on the compassionate allowance list, the Social Security Administration gets all kinds of clinical information and it's all kinds of review to determine if that condition meets the definition of disability. And that determination can take 3, 4, 5, 6 months. Where if your diagnosis falls on the compassionate allowance list, the Social Security Administration says, oh, look, this child or this adult has a diagnosis on this list. We don't have to continue to look anymore. We know that this diagnosis equals, oh, I meet the definition of disability. CdLS in its classic form and with a gene variant on the NIPBL gene is on the compassionate allowance list. The other gene variants are not. And the CdLS Foundation has started to apply to the Social Security Administration to include in the compassionate allowance list other gene variants that cause CdLS. So we're hoping that that works out well because it will definitely help families, but it is in process. Also on the compassionate allowance list is significant vision or hearing loss. So it is worth it to look at that compassionate allowance list if you're going to be applying for SSI to see even if your child has CdLS with a different gene variant, are there other diagnoses that your child has that are on that list? Because making sure that those diagnoses appear on your application can can speed up that clinical determination. Also, there are financial criteria, and this is where the fun really starts, that if a child is under 18, some, but not all, of the parent's income counts as the child's income. And this very convoluted, complicated process is called deeming. And the Social Security Administration takes a look at a lot of things and determines a dollar amount that is deemed to the child to be the child's income. And deeming stops the month after a child turns 18. And the dollar amount that they deemed is subtracted from the total amount that you could get from Social Security as an SSI payment. And if there is a balance there, you meet the financial criteria. And if a child is over 18, they also count income differently, but it is the 18 and plus, the 18 and over person's income and their resources. So if you want to explore whether your child is eligible for SSI based on the parent's income, you can either review the eligibility criteria, which is on their website before starting the application, or you can contact us. We have some specific information because it is complicated. And I set up a spreadsheet because nothing in my life is complete without a spreadsheet that kind of goes through their formulas, and you can kind of see if it's even worth it to apply for SSI if that is your concern. If your concern is that based on parents' income, my child will not be income eligible for SSI. If you review the information online, Social Security does have a toll-free number for questions. You can always appoint someone as a representative to help you, and that person can go to SSI appointments or be on the phone with them. You can also create a My Social Security account, and you can keep checking it to check on the status of your application. And if your application is denied, there are 4 levels of appeal. But applying for SSI is a lot of work. And so I think if you would want to, if your concern is, is this even worth it? Maybe that's something we can talk about based on your individual consideration, and that can help you make your decision if you're going to move forward or not. If you're applying for a child, you cannot apply online. I don't have a reason for that. I just know you can't. There is a child disability starter kit, which is actually very helpful, and I would urge everyone to take a look at it and use it. And there is a 1-800 number Monday through Friday, or your local Social Security office. If you're applying for an adult age 18 plus, you can apply online. And the Social Security Administration has about these are pages on their website that we've tagged that may be very helpful on determining income for children under and over 18, the compassion and allowance list, what the Social Security Administration considers a resource that counts versus a resource that doesn't, the disability starter kit. I mean, we've kind of tagged a lot of pages for you that might be helpful that are all on the SSA.gov website. And advocating with providers. This is, we have a lot of information about this, which is a little bit different than your health plan, in our healthcare notebook. So we have created a CdLS healthcare notebook. You can find it on the website as well as another webinar. I did that webinar too, so I would urge you, if you're sick of hearing my voice, to wait a little bit before you listen to that one. But also there are some information that we put together with our empowerment team, which is a wonderful group of CdLS adults, on questions to ask the doctor and how to practice and prepare and plan for doctor's visits. And we can certainly send those out to you. But there is a way to advocate at the doctor's office by planning, by making sure you know where you're going and getting there early, reduce your wait time, schedule first thing in the morning, or that 1 o'clock appointment after lunch. That's my favorite because they're not running late then. Making a list of your questions, bringing somebody with you, and asking if there are tests or screenings that are due based on age, gender, or health history, so that you're keeping up with regular and routine health care as well. And then also in our CdLS healthcare notebook, there's a lot of information about advocating during a hospital stay, because that is such a different environment. And we have a lot of information there, as well as questions on how to ask different things in the hospital, in order to advocate best while your family member is inpatient. But I wanted to refer you back to the healthcare notebook for most of those questions and more details about that. So that's kind of, in a nutshell, the presentation part of today. I'm certainly happy to take any questions. I'm trying to figure out how to get everyone to show again so I can see everybody, but I'm not really sure how to do that. So Gabby, maybe you could tell me.
So Linda, if you
We'll
just
take some questions.
yes, thank you. First of all, thank you so much, Linda, for the wonderful presentation. If you just stop sharing your screen, that would show everybody.
There we go. Yay.
So
And
we
we're
did have-
back.
we did have a few questions in the chat box. So the first one, I'll read it, is does having secondary insurance Medicaid through a state waiver program prohibit providers from billing for copay, even if providers only accept primary insurance, not Medicaid?
Can you read that for me again? I'm sorry.
Yes. Does
Okay.
having secondary insurance Medicaid through a state waiver program prohibited providers from billing for copay, even if providers only accept primary insurance, not Medicaid?
Okay, so waivers are, I can talk in general terms about waivers, but waivers really are specific to the state and often specific to the individual waiver. So what a waiver is your, in Connecticut, it's the Department of Social Services, but your lead agency for Medicaid, in whatever state it is, crafts what they're considering a waiver program, and they have to send that to be approved to CMS. And when that waiver is approved, it has general eligibility criteria. Who can you put on the waiver? How many spots am I asking for? What are the benefits for that? And the difference or the difficulty with a waiver is it offers, it's administered by the same lead agency that administers Medicaid in your state, but it's not really Medicaid, because a lot of things covered in the waiver are things above and beyond what a general Medicaid policy will cover. So there are services like, I'll use an example in Connecticut, and I hate to rely on it, but those are the ones I know
Linda,
the best. Yes.
she says this waiver is straight Medicaid from Maryland. I don't know if that will help your answer a bit.
I, not without looking at what was applied for. You know, a lot of the waivers, and I can look at it for sure. If you send me the name of it, I'd be happy to do some research. A lot of the waivers offer wraparound services that are not part of a regular Medicaid benefit. So they may offer housing support. They may offer a recovery assistant that comes in and helps individuals who are learning to live independently. They may cover respite. They may cover a lot of services that are not typically part of a Medicaid plan, but they are a Medicaid waiver because they are administered through the same lead agency. The providers, what the providers can and can't bill for should be part of the rules of that waiver. And if that agency required that the providers who provide services through the waiver are also Medicaid providers. And that can not only differ state to state, that can change within a state waiver to waiver. So in Connecticut, we have Katie Beckett. The rules for that are different than the Connecticut mental health waiver. They're different than the autism waiver. They're different than the community support waiver, because all of them were written at different times with different rules and submitted to CMS for approval for a different population at a different time. So without looking at it, it's hard to take, you know, it's hard without going to whoever is the lead agency for that particular waiver in your state.
Thank you. I'm actually going to ask the mom that's asking this question, because I think I might be asking it incorrectly, to unmute herself. I believe it's Amy. Am I asking your question incorrectly? Or so do you mind unmuting yourself to ask it properly if I'm not asking it correctly?
Sure, I'm sorry. Yes, I understand that waivers are extremely complicated and they're very state specific. So you did a great job. That's pretty much my question. I think you did a great job asking my question. I think it's straight Medicaid that we plugged into through the model waiver in Maryland. So I don't
Okay.
know what the straight Medicaid rules are for example, we'll have providers who Blue Cross Blue Shield is going to pay for, but I encountered when I was shopping providers, I encountered one provider who mentioned that possibly they would not take us because we had Medicaid as secondary insurance. And they thought this, the administrator of that office believed that they were prohibited from billing. If we had Medicaid, they couldn't bill us for any copay. They had to bill Medicaid. So, and they knew where to check. I just was wondering if you would happen to have an answer as to just generally Medicaid, but I understand it is state specific. Thank you.
In general, providers, and that is federal, in general, providers cannot charge Medicaid providers the copay, but that is if they take Medicaid. So if you have straight Medicaid and you go to a provider that doesn't take Medicaid at all, they're not enrolled in a Medicaid plan, whatever that looks like in your state, as long as they tell you up front, we don't take Medicaid and you're going to be responsible for the cost of this care, the federal government allows them to bill.
Okay.
They do have to tell you up front. That is kind of how the federal regulations read. You have to be informed that I don't take Medicaid. You can come here, but you're going to get this bill and you're going to be responsible for it.
Okay, thank you.
Laura, I know that you had a question. I'll read it out loud, and if you want to go into further detail, please go right ahead, okay? So Laura had a question. I have a telephone interview with Social Security next week for my 1-year-old
No.
who has a diagnosis with CdLS. Any advice? He's so young to be able to know how disabled he will be, and it seems like a mild case right now. So go ahead, Laura, if you want to talk a little bit more about that.
Thank you. I got a lot of good information from your presentation, Linda. So,
Oh, good.
yeah, so that was helpful, and I'll definitely be emailing just to get the resources and support. But and I guess as far as he's one and he has the NIPBL gene, and so I'm afraid they're going to ask questions, and I'm like, I don't know how limited he is because he's one.
Because he's one. You can have a sentence there.
Yeah.
I think the best thing to do is, have you looked at that starter kit?
I have printed off like the checklist, and I've briefly looked over the starter kit, but not in depth because I'm like going to block out my entire afternoon to just sit down with all of it.
Okay. Yeah. Oh, yeah. If you can.
Yeah.
And have a beverage later for when
yeah.
when you're ready, when you're done with it, have one cooling. But because it is mind-boggling, who stayed up all night and thought of these rules, for sure. Just take it from there. But I would go through the starter kit. I mean, your goal really is not to anticipate all of the goals that you're going to hope your child will or won't achieve. Your goal is really not to, look into the future. Your goal is really to look at what do they need now to make them eligible. So if you are looking at the starter kit and you are looking at the compassionate allowance list and you are looking at what information they need, then I would stick with that. You're not going to be able to look into the future. But that this is a gene variant. There is no fix for the gene variant. So what he looks like functionally will change, but will this gene variant always be part of his history and his medical condition? Yeah, because we don't know how to fix that or change that or in every cell. So I kind of limit yourself out of that because there is no predicting the future. But I 100% encourage you to get a beverage ready and then go through this disability, that the child starter kit. If you go through it slowly, it is really helpful. It really is. And really try to make sure that the first time that you fill out that application, that everything that you can find on the compassionate allowance list that applies to your child is on that application. Because honestly, your main goal here is to fill out that application once and not to have to appeal. So I would go, and I would not worry as much about, geez, functionally, what is he going to be able to do or not do at 6 or 10 or 11 or 15? Because
I just feel like with the application, it's, I mean, point blank, how is he not able to function day to day? And it's like, well, I mean, he is functioning day to day. He's just very limited in what the right thing to say, you know?
Right.
And I have avoided doing this because of the entire process. And then I had one quick question, and if I need to save it for an email, but this question is easier to say. I was on the phone with early intervention, and we need to get braces for my son, or AFOs, and the PT, the physical therapist, when she was asking if I was applying for Medicaid or Social Security, you know, all that, I said, yes, we have Blue Cross Blue Shield, hopefully we'll get Medicaid. And then she made a statement that said, well, I hope that doesn't limit us with what we can purchase. And I'm in Alabama, so that's all I have to say about that. So I didn't know exactly if they are canceling each other out, or they're like working against each other or something.
They shouldn't be. They shouldn't be. And I don't want to second guess what she means, but there are certainly there in certain circumstances, different Medicaid plans will say we will cover this, but not this. And it could be a model. It could be how often can I replace these as your child grows. It could be there's a lot of hoops to jump through to prove medical necessity to get them either reconfigured or because kids grow. You're not going to stay in the same AFO. He's one. You know, so to get new ones, how often can you get new ones? Can they be adjusted? There may be limitations for that. But we can cross that bridge when you get to it. There are often some other resources. I don't know if there's a Shriners near you.
No, South Carolina's the closest.
Okay, but maybe we can talk about if that becomes an issue once you talk with a physical therapist about maybe other resources that we can work with, because or what are the limitations? Are they on a certain brand? Are they on how often they can be replaced or modified? Sometimes if there's a good clinic, they're not really with the prosthetist, I can never say that word right, but on staff, they can manipulate them instead of replacing them. So there's some different options, but yeah.
Okay, thank you. Thank you so
You're
much.
welcome.
If anyone else who is on the call has questions, please, feel free to raise your hand or unmute yourself. We had we had a couple other questions from individuals who were not able to attend, so I'm going to just go through those questions now. But again, please feel free to raise your hand or unmute yourself. So we did have one question, Linda, that came through from someone that couldn't attend. They said, my child has CdLS. Can they automatically stay on my insurance after the age of 26, or is there some specific action I need to take?
The specific.
Oh, Linda, I'm so sorry I muted you.
Well, that was not nice, but I thought you were my friend. The specific action to take is two things. One is to find out what type of insurance you have. So if your plan, if the insurance is through your employer, if your employer takes on the risk of the cost of care, that's called self-insured, and they make up their own rules for everything because they're assuming the risk of all the cost of care. If your employer contracts with Blue Cross and Blue Shield, and Blue Cross and Blue Shield is at risk for the cost of care, that's called fully insured. So it really depends on A, what type of plan you have, and B, what state you're in. Because your state, whichever state someone is in, may have a law that says, you know what, if a child is disabled and they have been on the same insurance plan before they were 26, you have to be able to keep them on. And some states do not. So that really is state to state. But on the insurance end, if your company, which is often like a state employee or a town employee, is self-insured, where they assume the risk of the cost of care, they make up their own rules. So all that goes out the window. So it's those two things to figure out what you have.
Perfect. And then the last question I have is, I live in Alabama, but I want my child to be seen at CHOP, which is Children's Hospital of Philadelphia.
Philly.
Oh, in Pennsylvania. How do I get this through my insurance?
Again, it goes back to sort of reading the fine print. Do you have out-of-network benefits? And if you have out-of-network benefits, how do I access them? And what is the patient responsibility for seeing them? So if I have out-of-network benefits, does that mean in order for me to use my out-of-network benefits, can I use them at will? Or do I have to say, I tried an in-network provider first and they were not able to meet my needs, or I need a service or a procedure that no in-network providers perform? So you really want to go to your health plan, because all of this is negotiated between the health plan and your employer. And so there are very few health plan policies that come off the shelf and are purchased by an employer as is. You know, they're all kind of tweaked to meet what the employer wants to offer and what the employer can, quite frankly, afford to offer. So, and in my experience, the health plan, will sell just about anything the employer will buy. So they're all very specific, but you really do want to know, what are my out-of-network benefits and how do I use them? If you want to go to an out-of-network provider like CHOP, they do have a whole office that will deal with your insurance and find out what your patient responsibility is, because they're interested in getting paid as well. So part of that is, I would urge people to call themselves, but I would also urge you to use with the facility that you want to go to and make sure that those two things match.
So we just had another question come in, and it is long-term care insurance available to minor children, and at what age, and is also long-term care insurance offered by federal employers?
Yeeks. I don't really know if I imagine long-term insurance is offered for children, because you can buy it at any time. It's usually offered separately. I am not aware of any employer that offers long-term insurance that is stays with you even when you leave that job. So, and that there may be, but if it is, I don't think that that's common. Usually you are contracting directly with an insurance company that offers long-term coverage, and you're paying into that long-term coverage so that it is available to that person when they need it.
So another question, Linda. Any tips for navigating adult healthcare for CdLS versus pediatric healthcare?
Are there different things that you're thinking of? I mean, certainly you want to make sure that an adult with CdLS either is covered after they're 26 by Medicaid and then Medicare if they have a disability, for longer than those months. A lot of people will end up with Medicare primary and Medicaid as secondary as an adult, and that is called dual eligible. But you still want to read the fine print and everything. You want to see what your state offers as far as Medicaid. I would never suggest anybody just have Medicare, because it just doesn't cover enough no matter who you are. There's too many services that are not built into Medicare. too many pharmaceuticals, dental, vision, like there's just too many services that Medicare doesn't cover. So I would always look for either a supplement or Medicaid as secondary, which it would seem that most adults with CdLS would be eligible for through Medicare and Medicaid as a dual eligible.
Well, I would just wanted to double check with anybody else before we end our session for today, if there's any other questions.
Gabriel, this is David Molzak. Can you hear me?
Yes, David,
Oh.
how are you?
Good. I finally got my mute to work here.
Oh, great, great.
Welcome.
Well, Linda, you got to the point where I was, because our daughter's 28 years old and she's under my wife's health insurance at work. And they allowed that for the last 3 years. But you're right, it wasn't a simple, just can we do that? They made sure she was eligible. But we're looking at the next stage now, and you just opened up what I was trying to understand. She already has, we're in Massachusetts, she already has our mass, she's covered under Mass Health, but that's the secondary, because the primary is United Healthcare, which is what my wife has. You just asked the question, or sort of answered the question. We want to retire sooner or later, and we were told by somebody at Medicare that she would be eligible because she's got SSI, and therefore Medicaid would be the secondary and Medicare would be the primary. And you just opened that up. I thought that's perfect, because you exactly said the right thing, is that Medicare doesn't cover everything. And she just went through a hip replacement surgery. And I have no idea how that's covered by Medicaid or Medicare, but I guess, are they combined somehow? I guess I'm just confused.
Medicaid is generally the payer of last resort. You will see that in a lot of their literature. And then there's usually a small asterisk that says, unless you're on tribal land. But Medicaid is usually the payer of last resort. So whatever else your daughter has, where she switches from United Healthcare to Medicare, that other insurance, Medicare or United, will always be primary. Medicare and Medicaid do work together. The provider will bill Medicare first, and that portion that Medicare doesn't cover then goes to Medicaid. If Mass Health is straight Medicaid, the claim and if you use standard Medicare, like not a Medicare Advantage plan, the claim will go right from Medicare directly to Medicaid. If you have a Medicare Advantage plan, if that's what you choose for her when she no longer has United, they will bill once, and then it's a second process of them billing Medicaid for the secondary. But Medicare on its own, and I would take the CdLS out of it, Medicare on its own does not cover a lot of services that a lot of people need. Medicare on its own also has a very high deductible for inpatient stay. It has limited days if you ever needed long-term care or skilled nursing facility. There are certain parts of healthcare that are just not covered. Pharmacy is super limited. Dental doesn't exist. Hearing aids, vision. Like, there's just a lot of stuff that is not part of a regular Medicare package. Some Medicare Advantage plans do cover some of that, but I would never suggest straight Medicare only for anybody. So it really is worth it to look at the Medicare Advantage plans in Massachusetts that for when you're ready, and see how they integrate with, her Medicaid as secondary.
Okay. Well, Linda, I appreciate that. I'm just thinking exactly the same thing, is that Medicare Advantage is, I don't know, it's been getting a lot of bad press. Where I've been reading is that because they, like you said, if it's out of network, they're not going to cover it. And Medicare would cover it anywhere in the country. But can't you get a Medicare supplemental plan that would fill the gaps?
You can. And again, it's all a matter of when you're ready, looking at all of those choices, seeing what providers you go to. You're right. Standard Medicare, just about every provider takes it, but there are just limits in the services that are offered, and there is the deductible, like if she needed to go into the hospital for a hip surgery, there's a deductible before they start paying on that. And if she needed to, or anybody needed to go to, say, a skilled nursing facility for some rehab before they came home after hip surgery or knee surgery or back surgery, or, pick your surgery, there's limits on those days as well. So when you're looking at Medicare, you really do have to look at, how do I make this whole? Whether this is a really good Medicare supplement, whether this is a Medicare Advantage plan with Medicaid, whether it is regular Medicare with Medicaid, like, how am I going to make this whole? Because I feel like the I that you have to use is a standard Medicare policy is not whole. Like, you have to
Right.
supplement it in some way.
Okay. Thank you so much. Appreciate
You're
it.
welcome.
Are there any other last minute questions or last questions that anybody would like to ask before we end for the afternoon or morning or evening, wherever anybody's calling from?
And please know that, I am here at the foundation. We have the family service email. We have the any of the Let's Get Acquainted, any of those forms, they all come to the same place, or that email. If this is over and you're thinking, oh, I should have asked whatever, we're here for that. No worries.
Absolutely. And then right after this webinar around 2:30, you all will be getting an email with a survey asking, please fill it out with your honest feedback. There also will be a link to the Ask the Expert website. So if you want to submit a question, there's also a link to the family service email address. So if you want to submit it that way. So all that information will be being sent to you after this webinar. And then we will upload this webinar to our website. And then we will let you know when that is available as well. We'll post it on our social media pages to let you guys know it's available. So thank you.
Thank you very much.
Oh, yep. Thank you so much. And have a wonderful evening or afternoon.
Afternoon.
Bye-bye, everyone.
Bye. Thank you.